Thank you. I think we had a robust discussion about strategies to stimulate or catalyze activity in nursing credentialing research, and we took some liberties with the questions that were assigned. I think the first question that we were asked to address is whether there was enough evidence to pursue research in nurse credentialing, and to that there was essentially universal consensus that the answer is yes, with caveats. Those being that the amount and the quality of evidence for individual credentialing or linking individual credentialing with outcomes was not at the same level or the same degree of rigor as found with organizational credentialing. We didn't address so much the evidence for teams and where that is, but I suspect that it would fall in somewhere in between the individual and organizational credentialing. A number of people also commented that the evidence in this regard is different between whether it's mandatory or voluntary credentialing, and that the evidence, both the strength and quality, is better for mandatory than for voluntary, and that overall the evidence linking individual credentialing and at least patient outcomes was generally weak and of poor quality, and conversely for organizational, as I already said, was of higher quality and stronger. We were next asked to consider short and longer term strategies for catalyzing credentialing research, and the two framing questions that were given to us, which we abandoned after some discussion, was what might fall into the 1 to 5 year time frame versus the 5 to 10 year time frame. And the sense of the group was that distinction according to those time horizons was too arbitrary, and that there were some things that needed to be done early and soon and that were related to each other, and then there were some other things that probably would be of more value later on, but that trying to parse them into two discrete buckets was more than could reliably or realistically be done. I would also note that there was throughout this discussion some dynamic tension between parsing out the strategies to stimulate the research versus the strategies themselves and what the research questions were. And obviously there's some overlap, but there's also those are somewhat different buckets, and how you think about the question is somewhat different. I think consistent with, well, just one other general comment, the overall, if I were to try to lump the conversation to discrete buckets, things fell into the 7 categories that are listed here, and perhaps that's the bane of once upon a time being an epidemiologist. You always try to lump and group things. But the first, and much of our discussion, I think, or at least sounds like it echoed the discussion that occurred elsewhere, was getting the data house and the information management tools in order. There is substantive amounts of data out there in different places, but it's not organized and collated in a coherent or particularly usable manner. So the sense was that some effort should be given to consolidating that data and assessing what actually is there, and what of that is important and useful, and where are the data gaps, and then what needs to be done to figure out those data gaps. And while data is in many ways a topic in and of itself, the information management tools that you need to assess the data is a second, but they are inextricably linked. And so we really have to think about both the data and the tools that will then be utilized, and how those tools, whether they're electronic health records or others, things can be used to facilitate the data, and conversely, and it gets all intermingled. But overall, the sense was that this was a foundational issue, and if the data house and the tools weren't there, not much in the way of good research was going to be done. Second, and related to this, was, as was discussed in the last session, what are the priorities for research? And I guess I was somewhat surprised, but the sense of the group was that there actually is pretty good agreement on what those priorities are or should be, but that there is perhaps a need for an entity such as the IOM to clearly articulate what those priorities are, obviously in partnership with the enterprise. But there needs to be clear understanding of what the questions are that need to be answered, which of course ties into what is the data and how you're going to answer it. So again, these things get very linked. A third area was felt to be the need to implement a strategic communications plan, including a consumer advocacy component. And I would just note that from much of the work that I've done over the years, this is the single area that is most often overlooked in any change management effort, is the strategic communications. What's the message? Who's going to carry the message, et cetera, et cetera. And this, I mean, I can share one small anecdote that when I was at the meeting of the standing committee, whenever it was last year sometime, and at the airport I encountered a well-known senior physician in academic medicine at the airport who, you know, in the usual banter, you know, what are you doing here, et cetera, I explained. And his question was, what's nurse credentialing research? I mean, didn't understand what the question was and what the topic was. And I think it kind of underscores the point that there is a need to better articulate what this is all about, why it's important, why there is a need for research. And again, this links to the fourth bucket of getting money to fund this effort. If people don't understand the issue, and if they don't understand why the issue is important and what the demand is for it, then it's going to be harder to identify funding and why, whether it's philanthropy or government or professional organizations or high net worth individuals or whoever is going to fund it. So, and moving, I guess, to that fourth bucket, one of the axioms of research is that if you put forth money, researchers will be found. It's the universal elixir for research. So, you know, if money can be found, there will be research. But I think, given the realities, we need to figure out why that research. We need to identify what are the incentives, why organizations, whether they be philanthropic or government or otherwise, would want to invest in this area, what's in it for them. There was some discussion about the need for organizations to self-fund these efforts. Currently, in today's value-based healthcare economy, or at least the emerging value-based healthcare economy, there's a whole lot of things that seemingly would be in the best interest or in the self-interest of organizations to be exploring as to whether these, you know, credentialing of various types, individual organizations, et cetera, actually add value and helps the bottom line. I know, and to echo the editorial comment I made, I'm struck by how little academic health centers, which tend to be large systems, have invested in this area. And typically the ones who have schools of nursing and a nurse research enterprise and a large delivery system, and how rarely the two meet and come together and actually find that there's areas of mutual interest. That we could say the same about many of the large integrated delivery systems in the private sector. And indeed, some of these organizations like Kaiser Permanente or VA, others have found that the research component is a very definite strategic advantage that allows them to answer the questions that they need to provide more cost-effective and high-quality care. But there's a lot of other things we could say about securing funding and the need to do that, and I will defer in the interest of time. And all of these things kind of fell in the short term, and kind of in that same realm was this idea that there needs to be more of a focused effort to build research capacity and infrastructure at the organizations. You know, we often talk about, well, we can get students to do this, that, or the other thing, but that may not be the best strategy in the long term if you want to do this research on more than just an episodic basis, and ideas such as getting endowed professorships in this area, creating centers, getting the HSR&D folks more involved, et cetera, are all things that could be done to build that organizational research capacity, which would, in the long term, is going to be necessary to do this or to answer the sorts of questions that I think people would like to see answered. In perhaps the longer term vein here is identifying what are the better or superior models and analytic methods of research. Obviously, it takes a certain amount or quantity of research before, and diversity of research before one can actually sit down and say, this is a better ways of answering these questions than others. But in the long term, there has to be answers of what are the best ways to answer these types of questions, and what are the superior models to do this. And then finally, the last category, which was not perhaps as refined as it might get, is this idea of mandates as a stimulus to research. And perhaps one example, and I should say that it remains a somewhat controversial example, are nurse staffing ratios in California. And that mandate has actually stimulated quite a bit of research. And there are other examples that one could point to where an actual or threat, promise, whatever the right word is there, of a mandate actually in and of itself can catalyze research to answer the question whether this is a good or bad thing. And this could be tied to licensure, to accreditation of facilities. I mean, there's a variety of ways that one could affect mandates. And I should say that I don't like mandates, but it is nonetheless a strategy that is not uncommonly employed in at least in the public sector. And so that's something, at least over time, that is something that perhaps should be considered, is whether this is a tool or a lever that could be utilized to encourage research in this regard. And I think with that pretty much covers. I would defer or ask the members of the group if there were things that were either mischaracterized or were left out, or otherwise there's a need to verbalize something. And we still have some time to do that. Okay.
All right, we'll open the floor for questions. Let's see. I'll just start by reflecting. I'm not a qualitative researcher, but if I were, I would say that I've heard data 3 times. You know, that one of our major problems is that this data infrastructure, the lack of harmonization of data, the lack of the ability to conceptualize and operationalize the variables in a meaningful way, and the availability of data has come up again and again. So thank you. That I think we're starting to see similar themes. So, and I'll call on anyone else that's a qualitative researcher to help me with some of the other ones. That one was an easy one. So, so I'll start if there are no hands up. Let's see, anybody else? Would you like to ask? Okay, all right, very good. So when you talked about the priorities, in the sequence and not being 1 to 5 years and 5 to 10, that really it's a matter of setting priorities. And you made a recommendation, or excuse me, it wasn't a recommendation. You thought that the IOM could set priorities. And I just wonder, I mean, to me, we are the IOM here today. And I don't, so are you asking for somebody outside of the room to set priorities? Or are you saying we need to bring another small group together to help us refine those priorities?
No, I think the question that was posed to the group was, should the entity that articulates the priorities be independent from nursing enterprise per se, so that there is not a real or perceived conflict of interest? I mean, for lack of a better way, that most any of the organizations could certainly be perceived to have their own agenda, and regardless of how pure and white their heart may be, there's always that risk of perception. And so I think occurred, and the group seemed to resonate with the idea that in partnership with these entities, independent group, whether it's the Institute of Medicine, whether it's the National Quality Forum, or whether it's some other entity that is viewed as having broad stakeholder input and independent and only having the public good in mind, would be a better source to articulate these priorities than perhaps any one from within the sector. That's a very wordy response.
No, thank you. That clarified that for me. So thank you. And I'll have to say a number of times during our open session yesterday, the issue around patient-centeredness came up. And we never really coalesced around what that meant in terms of credentialing. So I'm assuming that thinking about bringing some external stakeholders together would mean that we actually, I mean, you recommended that, use the word again, I'm sorry, that you suggested that patients should be involved in this kind of stakeholder engagement.
I do, but I also recognize that if you want to elicit a MIGO response, my eyes glaze over response, just mention nurse credentialing research to patients. This is where that strategic communications piece comes in, that the term, and even if they understand what the words mean, how that relates to individual care. I mean, this is not something that has a lot of traction at the moment. So while yes, I mean, philosophically, I think patients are the center of the universe and should always be included in the discussion, but unless they are appropriately and meaningfully informed, they can't participate or engage in the conversation in a real meaningful way.
Yeah, and I would say I completely agree that, the health system is a black box. They know what they expect from us. They expect that we're providing the care that they should receive, and they trust us. But,
sometimes.
So most of the time, for the nursing community, I would say. No, that wasn't.
I'd have to agree.
But I think what a patient can tell us is something that always, it just amazes me, because a patient can tell you what they expect. And then within our minds, we can figure out how we can get there. So they expect that they're prepared when they're discharged home. We know what goes into assessing their family situation, assessing their environment, understanding whether they need home care. So all the things we do in discharge planning and our education. So a patient can tell us where they want to go, but, and that's the great thing about adding them to a discussion about that. So if you back it up around what a patient tells us they need from us, or the outcomes that are most important to them, and we back it up, there are particular standards and competencies associated with what we need to do to provide that care for them. So that's how I back it up into a credential. And you're right. It's if you ask a person about, well, do you want a credentialed nurse, or how important is it to you to have a credentialed nurse? That's a question that's a very odd question to them. because they believe that we are providers that provide the right care for them at the right time. And,
Aren't you all credentialed?
That's right, that's right. But the question is, what is it that you need from us, and how can credentialing help us get there in the quality and safety arena? I'm thinking aloud. All right. I'm going to keep on asking questions if you don't. All right. Anybody else? Okay. So another issue you brought up was around it was around the data, but you also called some of the, I think, infrastructure tools, and you gave the example of an electronic medical record as a tool. And I'm wondering if you can tell us a little more about what some of those other tools might be. Are they data sets, mechanisms to harmonize the data sets? Are you seeing some kind of registry data?
Yeah, I mean, there's a plethora of information management tools that exist. The electronic health record is the one that is perhaps most obvious in people, but health information exchange, there may be a role here. I mean, an HIE in the community is what an EHR is to the hospital. Registries of various flavors may well come into place. There may be other special or carved out databases that you establish for this. So, I mean, there's, you need to look at what the tools are and how they can be brought to bear. But it's not just EHRs.
So just a couple thoughts while I'm listening to this conversation. This is really interesting. When I'm thinking about the data tools and the information, and I'm thinking about the last conversation, the last presentation with the model, I think that, I'm struck by how important it is to have a model with the level of specificity that it is, so that you can identify, what are the core sets of data that would help you to identify those factors, and how important that is with prioritization, in terms of, what are the research questions, and then how does this relate to the model, and then what are the data we need to get, and then you can figure out where you need to go. So is this going to come from the EHR? Is this going to come from some administrative data set? Because I think it's important for us to look at what are the low-hanging fruit, what are our priorities, what data are easier to get, and maybe we can do some earlier research in those areas, and then where do we need to do more communication to get people to understand why they need to structure these other data sets a certain way so that we can do research. Just some thoughts.
Yeah, and I think having clarity about the priorities, at least in the near term, is intimately and intricately linked to the data and how you're going to use that data. So, they're linked, but they're also fluid, and that over time they're going to change. So this is, there's a continual process of what are the priorities and whether the data supports that. I mean, we're going through a big conversation right now with the use of cancer registries and how cancer registry data can be used for quality improvement purposes, because cancer registries kind of evolved for one set of purposes that is different. It really wasn't on the radar for today. And how do we change what's in cancer registries so that it can be used for quality improvement purposes? And that's just one of many examples.
So thank you. So Pam, go ahead.
So similarly, linking back to the model and and talking about the data information tools that we need and priorities. When I think about the challenge of research that is not just unique to nurse credentialing, but when we start then broadening that to teams, did you have any sense of how difficult that would be? And for this particular subject, that again, talking about how do we catalyze research about nursing credentialing, did you think about or did you come to any conclusions that we really couldn't broaden that reach to really look at the team concepts because perhaps the data and information are not available about other team members, or even in the model when we talk about the care that's being provided, because we have that one arrow that actually comes down to the nurse outcomes, but the rest of it in my head is a little bit fuzzy as to how we would deal with the attribution and separate those out. So did you, again, are we thinking we need to be a little bit pure on the front end here as we increase the research, as we look at the research priorities specific to nursing versus team?
Yeah, I mean, 2 or 3 comments, I would say. I mean, the short and easy answer is, in the group, we didn't explore that, and we didn't come to any sort of consensus or opinion in that regard. So I could leave it there, but I would go on to say that, teams, healthcare is about teams, and then certainly the future is about teams. So we have to do that. And while that may be a bit messier or muddier than looking at nurse credentialing per se, on the assumption that that's not messy, there's nothing that will make that better or give clarity than beginning and starting to identify the data and use the data. And, it's kind of like performance measures. Nothing makes performance measures better than using them and finding out how they are flawed, and then you refine them over time. And it's much the same with data. Is that, you start, and as you use it and progress, you'll find out how to either collect different data or better data, or somehow it will improve with use.
All right, so let's just do a spot check. Did they get everything? Are we done with that one? Okay, excellent, thank you. Okay, Linda, group 4.